5 months of pregnancy, I felt fetal movement regularly, but recently I do not feel fetal movement. They are very much anxious, and you have to examine the patient and diagnose the condition, why it happened, that is causes, and investigations to be done, confirmative investigations to be done. Then comes to the point of management. And then after treatment, what can we do? Intrauterine fetal death and stillbirth are traumatic and devastating events for the couple, their families, and also for the obstetrician. Obstetrician, what will say, how he or she will break the news to the couple. So this is very much devastating for the obstetrician also. The cause of death must be identified and explained, and further management must be discussed. Fetal death rate is around 35 per 1000 births in India and around 7.5 per 1000 births in USA. In our West Bengal, recently 2016, the rate is 4 per 1000 birth. Incidence of IUFD. There is gradual decrease in the incidence of IUD due to preconceptional care, better care throughout pregnancy, prenatal diagnosis of congenital malformation like anencephaly, like multiple congenital malformation that has been being diagnosed by anomaly scan at 18 to 20 weeks, and then plan for termination, selective termination. All these reduce recently the incidence of intrauterine fetal death rate. Definition. What is the definition of intrauterine fetal death? Intrauterine fetal death refers to a fetus with no signs of life in utero. Fetus means, see, the product of conception has not delivered. It is in utero. And signs of life is, most important is heartbeat, that is cardiac motion, and limb movements also. The cardiac motion is absent in the fetus in utero before delivery. Usually it is after 28 weeks of pregnancy. Stillbirth is defined as delivery of a baby after period of viability with no signs of life and includes all fetal deaths occurring after 28 weeks of gestation, during pregnancy and during labor is stillbirth. But IUD is before delivery in utero. But stillbirth as a whole, as a total, after delivery, no sign of life, so that is stillbirth after 28 weeks of pregnancy. As per WHO, stillbirth defined as a baby born with no sign of life at or after 28 weeks of gestation, or fetal weight more than equal to 1 kg, that 1000 gram. This definition is followed in India. In United States of America, stillbirth is defined as loss after 20 weeks of pregnancy, and United Kingdom it is defined occurring after 24 completed weeks of gestation. But in India, we take 28 weeks after 28 weeks of gestation. Now we come to the causes of IUD, Intrauterine Fetal Death, IUFD. Causes, fetal causes. Fetal causes, 25 to 40% is fetal cause. Most common হচ্ছে congenital malformation of the fetus or chromosomal defect. Congenital malformation may be due to chromosomal defect or non-chromosomal. Non-chromosomal disorder, that is complex congenital heart disease, is cause of IUD. RH isoimmunization. In case of RH negative mother, husband is RH positive, there is every possibilities of RH isoimmunization. If isoimmunization occurs, that may be a cause of intrauterine fetal death due to hydrops fetalis. Due to infection. What type of infection? Now, congenital syphilis, cytomegalovirus, toxoplasma, parvovirus, rubella virus, varicella infection, and listeria. All these infections can cause but can kill the fetus in utero, and non-immune hydrops. These are all fetal causes. Placental causes, placenta. Through placenta, the fetus get nutrition. So, if there is deficiency of nutrition, fetus in jeopardy and ultimately may die in utero. So, placental causes, number one is placental abruption, placenta previa through acute placental insufficiency. That is abruptio placentae, separation of the normally situated placenta. This is the acute condition. In acute condition, fetus will not get nutrition from through placenta, and ultimately IUD can occur. Placental and cord abnormalities. Chorioamnionitis, that is infection, chorioamnionitis. Intrapartum asphyxia due to obstructed labor. There may be intrapartum asphyxia of the baby and IUD can occur. In multiple pregnancy, twin to twin transfusion, TTS, twin to twin transfusion. One fetus get plethoric, more blood, and one fetus get less blood. So twin to twin transfusion, the fetus which gets less blood may die in utero. So twin to twin transfusion, TTS, is the most important cause of IUFD. Fetomaternal hemorrhage, bleeding from fetus to mother. If there is much fetomaternal hemorrhage, fetus may die in utero. Excessive coffee intake can kill the fetus in utero. Now come maternal cause. Maternal cause, diseases of pregnancy like preeclampsia, eclampsia, that is hypertensive disorder of pregnancy. Due to gestational diabetes mellitus, IUD can occur. Due to hypertensive disorder due to large placental infarct, abruptio placenta, and markedly small placental size. So ultimately, is placental insufficiency and fetus will die. Diabetes mellitus. Diabetes mellitus may be previously he is diabetes mellitus or gestational diabetes mellitus may occur in pregnancy. Medical disorder like heart disease, renal disease, that is chronic nephritis, hereditary thrombophilia can kill the fetus. Apla syndrome, antiphospholipid antibody, if there is antiphospholipid antibody, Apla syndrome will occur, there will be vasoconstriction and fetus may die in utero due to Apla syndrome. Obstetric cholestasis is a cause. Trauma, sepsis, acidosis and shock. Labor complication, that is prolonged labor, obstructed labor can cause IUD. Hyperpyrexia. Hyperpyrexia due to any cause like enteric fever, like malaria, any cause can kill the fetus in womb. Postpartum pregnancy, that is beyond 42 weeks of gestation, there is every possibility of placental insufficiency and fetus may die. These are all more or less maternal causes, and then unexplained cause. Unexplained, that is cause is not certain, baby fetus may die in utero. These are the all causes of intrauterine fetal death. Unexplained causes can be reduced to 10% by meticulous autopsy. Now we come to diagnosis. How will you diagnose that is a case of intrauterine fetal death? So we start from the history taking, that is symptom. The patient, what the patient will say. When the pregnant woman presents with absence of previously perceived fetal movement, it should raise suspicion of IUFD. Symptoms, patient may complain of decreased fetal movement or absent fetal movement. বাচ্চা নড়ছে না, পেটে বাচ্চা নড়ছিল, বাচ্চা নড়ছে না. Along with this, she may complain of brownish discharge per vagina. She may complain of pain abdomen, bleeding per vagina with or without uterine contraction. With this symptom, patient presented to you. What are the signs? If you examine the patient, what will you get? Now, regression of pregnancy sign like breast changes. Breast changes that occur in pregnancy, that will regress. Fetal heart sound are not audible on auscultation by stethoscope or Doppler and confirmed by ultrasound. Fetal heart sound is absent. Per abdominal examination, what will be the fundal height? Fundal height will be less than the period of it will be less than the period of gestation. Why? Now, because the fetus will undergo autolysis and decrease in size, in volume, and amniotic fluid will be less. For that reason, all these reasons, the height of fundus will be less than the period of amenorrhea. Parabdominal decrease in fundal height, decreased tone of uterus. Tone of uterus will be flaccid tone. Flaccid tone, and Braxton's contraction is absent. In pregnant uterus, if you place your hand over the abdomen, that is over the uterus will undergo contraction, that is called Braxton's contraction. You will feel the Braxton's contraction. But in case of IUD, Braxton's contraction will be absent. During palpation, if you feel the living fetus, you can feel the fetal movement. But in case of IUD, the absence of fetal movement. Egg cell crackling due to fetal death, there will be the autolysis of the brain matter, and there is looseness of the joints also. For that reason, you will get the egg cell crackling. ডিমকে যেমন এ করলে হয় crackling পাওয়া যায়, egg cell crackling feel of the fetal head appears after many days of IUD. After 7 to 10 days, you can get the egg cell crackling during feeling of the fetal head. Pathology. Depending upon the degree of maceration, by careful examination of the dead infant, time of death can be determined. কতক্ষণ আগে বাচ্চাটা ডেথ হয়েছে সেটা আইডিয়া পাওয়া যায়। কি কি দেখেন না, reddened skin in 6 to 8 hours. After delivery, if you examine the fetus, there is only reddened skin. You can say that just 6 to 8 hours before baby has died. Skin slippage and peeling. Peeling of skin is there. That is grade 2 maceration. It occurs 8 to 12 hours after death. Extensive skin peeling. Red serous effusion in chest and abdomen in 2 to 7 days. Grade 3 maceration. 2 to 7 days এইগুলো পেতে পারি। Excessive skin peeling. After 7 days, aseptic autolysis of the ligaments and liquefaction of other structures like brain occur, and there will be egg cell crackling, and if you do X-ray or ultrasonograph, there is Spalding sign. You can see. Will come later on what is Spalding sign. These changes are the basis of the typical radiological sign of intrauterine death. What investigation will you do? What investigation? Routine investigations. Routine in maternal investigations like hemoglobin, in maternal cause, maternal anemia and malnutrition also can kill the fetus. So hemoglobin, ABO-RH typing, because patient may be RH negative, so ABO-RH typing. Diabetes is a cause, so blood sugar, and infection. So for infection, you have to do torch, that is a toxoplasma, rubella, cytomegalovirus, herpes, listeria. All investigations are to be done to reach a diagnosis, and special investigations like antiphospholipid antibody, all these can be done from maternal blood. Our special investigation, ultrasonography. In ultrasonography, what will you get? Absence of fetal cardiac activity, reliable evidence of fetal death. Cardiac activity, cardiac motion is absent. Scalp edema, excessive scalp edema there will be. Halo sign there will be. Collapsed cranial bones which are overlapping. Due to cranial bones overlapping, irregular overlapping, that is called Spalding sign. Also provide the cause of death in some cases like abruption. If there is placental abruption, by ultrasound we can diagnose that. Oligohydramnias, sign of fetal hydrops will be diagnosed by ultrasound. So ultrasound is a most reliable investigation in case of intrauterine fetal death. Straight X-ray of abdomen, previously it was done, nowadays not done, because doing X-ray and appearance of Spalding sign is late. For nowadays, we have ultrasound we are in our hand, so we do ultrasound and confirm the fetal death early. Radiological signs of IUFD. This is a Spalding sign seen after 7 days of death. Collapse of fetal skull with overlapping bones due to liquefaction of the brain matter and softening of the ligamentous structure. There will be irregular overlapping. In overlapping of skull bones, in also seen in molding also. Molding. Where occurs molding in labor. So, in molding, the position of the head will be in the pelvis. But in case of Spalding sign, the head not in the pelvis. It may be in the pelvis if the patient is in labor. But usually, Spalding sign with the head is above the pelvis. That is not molding. But in labor, molding can occur. Molding is the overlapping of skull bone, but that is regular and not so much of overlapping like IUD. So, with these findings, we can differentiate between Spalding sign and molding. What is halo sign? Abnormal increase of cranial soft tissue due to maceration. Halo sign, scalpedema. Halo sign. What is Roberts sign? First sign of IUFD. Intrafetal gas within the heart, within great vessel. There will be gas shadow, large joints. Uncommon but reliable sign. Seen after 12 hours of IUFD. Roberts sign. Ball sign, that is hyperflexion of the spine. Ligaments will be loose and lax, so there will be hyperflexion. And there will be hyperflexion of the spine requires several days. Mild degree of curvature of spine may mislead in living fetus. What is ball sign? Hyperflexion of the spine. আর কি দেখা যাবে না overcrowding of the ribs. Overcrowding of the ribs, that is concertina effect. Concertina effect. Concertina যেমন হয় সব এক জায়গায় হয়ে যায় সেই রকম. Crowding of the rib shadow, that is concertina effect. You have diagnosed that it is a case of IUD. What maternal evaluation to be done in IUFD? From maternal history, what history to be taken? Now, is there any history of chronic hypertension, diabetes, SLE, systemic lupus erythematosus? This history to be taken from the mother. Past obstetric history, that is previous, is there any previous stillbirth or recurrent pregnancy loss, previous infant with developmental or structural abnormality, or is there any single gene disorder, previous gestational hypertension or diabetes, previous macrosomic or growth restricted babies, previous placental abruption, hypertensive disorders, previous hypertensive disorders or not. All these history to be taken for maternal evaluation and also family history. Is there any history of IUD in case in family, in sister, that is to be asked. Current pregnancy te ki korte hobe na BMI. Obesity is a cause of IUD. Obesity. So BMI and pregnancy weight gain. Is it a multifetal pregnancy? There is chance of twin-to-twin transfusion in case of monoamniotic, monochorionic fetus. Placental abruption, preterm labor or rupture of membranes. Is there any preterm labor or rupture of membrane, infection or chorioamnionitis, fetal abnormalities on ultrasound, that is fetal growth restriction, fetal structural anomalies. In current pregnancy, all these to be investigated. Then examination of the blood pressure, is there any proteinuria, size of uterus, is there any bleeding, all these. Blood test in present pregnancy, bile, screening for diabetes, antiphospholipid syndrome, clear bed kit test to rule out massive fetomaternal hemorrhage. If the pregnancy is Rh negative pregnancy, in case of Rh negative pregnancy, you have to do clear bed kit test to know the amount of fetomaternal hemorrhage, because you will give anti-D immunization, anti-D. Is it sufficient or not? That is to be ascertained by clear bed kit test. Indirect Coombs test to rule out Rh isoimmunization, and there is complications. I will come to the complications of the IUD, that is DIC, disseminated intravascular coagulation. There is every possibilities. The coagulation disorder may happen. Why coagulation disorder happen? Now, thromboplastin is released from the and decidua, dead placenta and decidua. These thromboplastin ultimately come into the circulation and DIC will develop. What is the level of fibrinogen in non-pregnant women? We have to test for fibrinogen level. In non-pregnant case, it is 250. In case of pregnancy, on an average 450. Our critical level of fibrinogen is 150. If you see the fibrinogen level is 100, that is very much serious. So, platelet count and plasma fibrinogen level, FDB, fibrinogen degradation products, if indicated, all blood tests to be done. Test for specific infection, that is cytomegalovirus titer, toxo titer, parvo titer, all to be done. Fetal evaluation, dead fetus. You have to examine the fetus to arrive the what is the cause of the fetal death. Examination of the placenta, cord and membrane. Examination of the placenta, cord and membranes along with fetal postmortem examination to be done. Couple is to be counseled for postmortem examination. Gross examination may reveal one of the following causes: placenta, weight, retroplacental clot suggestive of abruption, velamentous attachment of the cord, vasa previa, infection, meconium staining, all to be seen. Meconium stain or cloudy, if the membrane meconium stain, then thickening of membrane, foul smell. Foul smell is indicative of infection, amniotic fluid, color, volume, consistency, cord, true knot with sign of umbilical cord thrombosis or false knot, cord around the neck, arms, legs, pull-ups of hand, length of the cord, hematoma or stricture, is there any in the cord, Wharton's jelly, usually it is absent, but in case of IUD, there will be normal. Postmortem examination. Postmortem examination, very important part of the investigation for the etiology of stillbirth. But usually couple do not agree. If they agreed to do postmortem examination of the baby to be done, fetal findings to be documented during postmortem, weight, if the weight is less, you have to think for causes FGR, fetal growth restriction, weight, length, head circumference, abdominal circumference, measurement of limbs, structural any abnormalities, dysmorphic feature, relevant negative findings, detailed photograph, gross and histological examination of the placenta. Now come to the management and delivery of the fetus. If there is no immediate medical complication, we can wait. We can do conservative management. Usually, patient goes into labor within 7 to 10 days and deliver the baby vaginally. But today, the couple does not want to follow the conservative management. She will not agree to bear the dead fetus in her womb. The choice of method and timing of delivery depends on gestational age at which the fetal demise occurred, history of a previous cesarean section is there or not, that is post-CS pregnancy or not, maternal preference. Expected management, most of the women will deliver spontaneously within 2 to 3 weeks of IUFD, but it may lead to severe maternal anxiety. Most couple will not choose expectant management. Vaginal delivery is the preferred route unless there is definite indication for a cesarean section. Cesarean section korte hobe kothay? Mandatory if there is major degree of placenta previa. The placenta niche, bachcha berobe koto diye. So সুতরাং you have to do cesarean section. If transverse lie, if macrosomia 5 kg ওজনের বাচ্চা বেরোবে কি করে? In repeat CS ki 3 times cesarean section beforehand, in that case how will you deliver the baby vaginally? There is every chance of rupture of the uterus. All these are indications for cesarean section of IUD, otherwise vaginal delivery is preferred. Indication of interference, prolongation of pregnancy beyond 2 to 3 weeks, wish of the patient, falling fibrinogen level, onset of uterine infection. Immediate delivery indicated in conditions such as severe preeclampsia, eclampsia. সেখানে কি ওয়েট করা যাবে? যাবে না. Placental abruption, rupture membrane, chorioamnionitis. If there is any features of chorioamnionitis, you have to deliver immediately. Intrauterine induction of labor. That is medical induction, no surgical induction. If we do ARM, there is every chance of infection, ascending infection, and Clostridium welchii, dead fetus. So we will do medical induction. Medical induction can be done by oxytocin, misoprostol, that is prostaglandin gel. All these can be used for medical induction. Oxytocin, at time with favorable cervix is favorable, we can use oxytocin. In IUD cases, we will use higher doses of oxytocin, that is usually 10 units in 1 bottle of normal saline or ringer lactate, ringer solution. Will start drip at the rate of 30 drops per minute, and then I will gradually increase the rate of the drop. If the cervix is not ripened, we can use prostaglandin gel to ripen the cervix, or we can introduce Foley's catheter through cervix to ripen the cervix. And then we can use oxytocin for uterine contraction. Misoprostol. Misoprostol, if the pregnancy is less than 28 weeks, we will use higher dose, that is 100 to 200 microgram 4 hourly. Maximum 4 doses we can use. Or if it is more than 28 weeks, lesser doses is required. That is 25 to 50 microgram. 4 hourly, maximum of 6 doses we can give. But in case of cesarean section, better avoid misoprostol. We can use mifepristone and misoprostol. Mifepristone 200 milligram is given 24 hours before use of misoprostol. After giving mifepristone, we will prime the cervix also. After 24 hours of mifepristone, we will start misoprostol. It will reduce the induction time. 200 milligram of oral mifepristone followed 48 hours later by misoprostol, or 24 hours after mifepristone, we can use misoprostol. We can use 400 microgram or 3 hours of mifepristone. This is higher dose. No, 400 is not used. Usually 100 or 50 is used. Foley's catheter for cervical ripening. In women with a previous year section, what will you do? Cervix is unripe. To ripen the cervix, we may use Foley's catheter to ripen the cervix. Indication for cesarean section in IUFD: major degree of placenta previa, transverse lie, 2 or more scar on the uterus, that is the 2 বার কি 3 বার সিজার হয়ে গেছে, আর significant macrosoma, big baby. Postnatal management. Postnatal management, first হচ্ছে যে psychological support, counseling for couple and family, possible cause of fetal demise, risk in race pregnancy to be explained. Then comes the suppression of lactation. Suppression of lactation, today we use cabergoline. Cabergoline 0.5 milligram, 2 tabs stat we can use, or we can use 0.25 milligram of cabergoline twice daily for 2 days. In Rh negative women, 300 microgram of injection anti-D immunoglobulin to be given. Follow-up visit, plans for future pregnancy and preventive measure if any, and contraceptive advice to be given. What are the complications of intrauterine fetal death? Number 1 হচ্ছে psychological upset. Number 2 হচ্ছে DIC. Number 3 হচ্ছে uterine inertia, তত ভালো contraction হবে না. Number 4 infection. Number 5 postpartum hemorrhage can occur. Retained placenta can occur in case of IUD. So these are the all complications may happen in case of IUFD.